I'm Charlotte Coles. I'm Professor of Breast Cancer Clinical Oncology at University of Cambridge. I'm also an NIHR research professor, and I'm a practicing clinical oncologist. Radiotherapy is used as a really important part of curative treatment for about 2/3 of people with breast cancer. And we usually treat more than 30,000 people with breast cancer with radiotherapy per year in the UK. We usually give it after surgery, and it's to treat possible microscopic disease. And it's been proven to reduce the local relapse and can also increase overall survival for some people with breast cancer, particularly those at high risk of relapse. And we also know that breast cancer isn't just one disease, but it's made up of lots of different subtypes. And as we all know, there's been huge advances in the understanding of cancer biology and resulted in lots of different drug treatments that have tailored the treatment to subtypes. So this is called personalized therapy. But until relatively recently, breast cancer radiotherapy has been more of a one-size-fits-all treatment. So the research that I've been carrying out is part of a very large multidisciplinary team that addresses risk-adapted breast radiotherapy. So this is where the radiotherapy is tailored to give the best chances of cure with the least side effects. So I've been involved in 3 CRUK funded breast radiotherapy trials. They're sponsored by the Institute of Cancer Research, and they're managed by the Institute of Cancer Research Clinical Trials and Statistics Unit. So the first one's in Port Low, and it tested whole versus partial breast radiotherapy in more than 2,000 people with low-risk breast cancer. And we recruited right across the UK from 72 centres. What it showed at 5 years outcome was there are extremely low rates of breast radiotherapy recurrence across all the groups, but the patients reported less changes in breast appearance and breast firmness and hardness with the partial breast radiotherapy. So we're really pleased that this has gone on to change practice internationally. And what's great about it, it uses a really simple technique that can be used with all existing radiotherapy equipment worldwide. Following on from import, this kind of led to the CRUK funded PRIMETIME study. So it asked the question, can we go further? Can we use a simple biomarker that combines clinical information with routine immunohistochemistry and Ki-67, which is a measure of proliferation, to be used to identify people at very low risk of breast cancer relapse? And this is such that the risks of radiotherapy may outweigh really small benefits. And it means that we could potentially safely avoid radiotherapy altogether for some people. So just briefly, the final CRUK funded breast radiotherapy is in Port High. And as the name suggests, it's for patients at higher risk of recurrence. And it's investigated much more complex intensity modulated radiotherapy. So the radiation dose was deliberately modulated across the breast to treat regions of higher risk with higher dose and regions at lower risk with lower dose, all in 15 fractions, using a technique that we call a simultaneous integrated boost. So we recruited more than 2,600 patients from 76 UK centres, and we're just at the stage of submitting the 5-year results for publication. RadNet is fantastic. It's a network of 7 radiation centres of excellence all around the UK. And it came about as a result of a 5-year CRUK funded award in radiobiology and oncology infrastructure. And this was a result of CRUK's commissioned strategic review of investment in radiotherapy research. And what it showed was 3 major things. 1, that radiation research is really important. 2, that it had been chronically underfunded for many, many years. And 3 was that there was this disconnect between radiation discovery biology research and the radiotherapy clinical trials. And this created a block in translating benefit for patients. So one of the key strategic elements of RadNet is that it brings world-class scientists, and many of these may not have actually been involved in radiation discovery biology previously as one of their main themes. And this is important because this meant that they could look at problems with a different lens and bring fresh, innovative ideas and apply them to radiation research. So RadNet also nurtures really collaborative research across not only the 7 centres of excellence, but really importantly, includes all radiation research active centres. So what this means is that instead of working in separate silos, the whole radiation research community is able to work synergistically rather than duplicate effort. And this gives a much greater chance of bringing this really exciting discovery radiation research through into the clinic for patient benefit. I think on the discovery side, I'd pick the collaborative RadNet research with Flash RT. And as the name says, it's really exciting emerging radiation technology. And what it does is it's an extremely high dose of radiation given in just a fraction of a second. And it's thought it has the potential to destroy tumours with very little effect on surrounding tissues. So it's kind of like the holy grail of radiotherapy. Well, I think that we should be really aspirational. And what I'd like to see personally is a world where every person who requires radiotherapy has equitable access to the best possible treatment with the least side effects, wherever they live and whatever their background. And I think we can do this. And what it means is working together in partnership, not only to sort of counteract all these disparities that we have in the UK, but we have to think globally. Forming collaborative and mutually beneficial research partners with low and middle income countries is going to be really, really important. And there are actually currently huge regions of the world with no access to radiotherapy at all. So this is where I'd like us to be in 2042.